we have been working for almost a year to have Karen Seagraves join us. We have been, when we were doing our Joining Our Voices symposium last fall and talking about the role of technology and AI in serious illness and caregiving. We had that was the first time I had heard Karen's name. Steve Hahn introduced us, and then we've been playing the scheduling game, and she has been very patient. And I'm absolutely thrilled, especially since it's Alzheimer's and Brain Health Awareness Month. I will do her no justice with her introduction, but if you saw the title, she's going to talk with us about exciting uses of artificial intelligence, AI, for brain health. But if you see, she has a ridiculous amount of degrees that span both the clinical space and the academic space and the research space and the professional space and the entrepreneurial space. And so, Karen, welcome to the coalition. Welcome to Friday Facts.
Well, thank you very much. I hope I can do you justice with that introduction. But I'm
You
thrilled to talk
will.
to this group of individuals. Thank you so much for inviting me to come speak today about something that's near and dear to my heart. I'm thrilled to be on. My
Yeah.
background is clinical. I
Thank you. I was
started as
going to
a
say, but and
yeah.
I'm interrupting just to then not interrupt you later. We have a little tradition here before you get into the topic area. We like to get to know about you a little bit. So yeah, tell us
Oh,
you and where you're from, where you're going, but also yeah, what's your professional path that brought you to talking to us about AI?
sure. Okay. Well, my background is clinical. I actually was from New Jersey, but moved to Atlanta to attend Emory University and spent many years in direct clinical care, taking care of patients at the bedside, and then became an advanced practice provider. So I am a nurse practitioner and a clinical nurse specialist. And but then I moved into an administrative and leadership space for a long time. And in that space, I was able to also at the same time attend university and work toward my PhD in nursing as well and do some research there. So background mostly clinical. For those of you who are in healthcare, I also simultaneously worked for the Joint Commission, which reviews and accredits hospitals. And I worked in the stroke program. So I was reviewing programs for their stroke certification. My work was took me to Atlanta for about 30 years, and then I moved to Charlotte about 5 years ago. And the way I was introduced to your group was I volunteer with the AARP, and I serve on the executive council for the Charlotte region. So that's how I know Steve,
Oh.
and that's how he introduced me to you. So
That helps because for those of you who don't follow Karen on LinkedIn, you should do it. And then you see there's so many interesting things that you're involved with. I was like, what was the connection? So thank you for putting that together.
sure, sure. And really the common denominator is that I really care about patients and I care about their families. And so everything that I do has that in mind, which is what drew me to artificial intelligence. There are a lot of fears, around AI in healthcare and a lot of concerns from clinicians about being replaced and concerns from patients and families about data security and privacy. And um, there's a lot of ways to do it so that when we do it well, those things aren't a concern. I think of artificial intelligence as an augmentation of human intelligence, not a replacement. I often tell people that it's not artificial because humans devised it, right? This came from us.
Oh, this is helping me
But
feel better. Thank you.
yeah, and it helps us to do things that would take us a really long time to do manually, if you will. And I also like to remind people that there are things we use every day that we don't think of as artificial intelligence, but that we trust implicitly. We pick up a calculator and we're very perfectly fine punching in a number and accepting the answer, right? Instead of doing long calculations with a pencil and a paper. So if you think about that from an early perspective, it's the same thing as putting on a pair of eyeglasses, right? We can't see something with our naked eye, but if we put glasses on, we can see it, right? It's the same thing with artificial intelligence, where very often we need to overlay something with software or a program or an algorithm so that we can see something that we can't see with our naked eye. So that's how I think of artificial intelligence in healthcare.
Okay. All right. So that was good. And ironic, the AI and tech conversation we had for our symposium was on Halloween because I was like the scary and spooky AI. But I know, and this group knows
Yeah.
I'm obsessed with ChatGPT just from like a note taking. But go into the, I'm going to make up a word, algorithmicness, because I have been reading a lot about the helpful and predictive nature. I was
Mhm.
just seeing things this morning after I told folks not to go on, and I saw on LinkedIn. So tell us about, and I love the use. You were like me. You put the word exciting in. That's a Heather thing to do in a title. The exciting uses. So what are some of the things that you are seeing to? I'm going to keep using that word augmentation because I like that a lot, or algorithm.
Sure, sure. Um, well, since it's Brain Health Month and I work in the neurosciences space predominantly, I think I would like to talk about a few of the artificial intelligence tools or resources, if you will, that we are using and some that are being developed right now in that space.
Okay.
So one of the pieces you just mentioned, ChatGPT. So there's the ability to sort of generate a lot of information quickly from information that's already out there, right? And we teach it, we train an algorithm by practicing, right? We add more and more information to it, we tweak it, we try to teach it, yes, that's right, no, that's wrong. And I like to share a sort of a piece around being skeptical of some of that chat GPT stuff. It does have hallucinations.
Mhm.
A favorite of mine, it was a story I heard from a colleague speaking that you can use artificial intelligence to ask it to create an image for you, right? You can say, create an image of, five people sitting on a Zoom call, and it will pop up an image. So
Okay.
they said to create an image of salmon swimming upstream. And when the image was created, it was actually a fillet of salmon swimming upstream.
Okay.
So it's all about how you train your algorithm to do things correctly. And I taking a step over from that natural language processing, that's where you can use if just to use a simple term, a machine, to read and understand and interpret language. So if you listen to books on tape and you're doing that, that's really coming from, it can actually, or if you listen where it's actually reading the words, it's just simply understanding this is what the word says, this is how we say it out loud. But
Mhm.
taking it a step further, I want to focus on electronic health records. So we all know that that's replaced writing notes and charts and different things in doctors' offices and in hospitals. And we have so much information that the idea of the electronic health record was to make sure we didn't miss things.
Mhm.
However, if any of you have ever taken care of a patient with a serious illness or someone who has a chronic disease with many years of treatment, or a trauma patient who has multiple systems involved.
Almost all of us, either personally or professionally or both, go on.
So imagine if you tried to print that health record out, it would probably be, several feet tall. The problem with it is if you're going to use it to make a decision quickly, like that patient presents to the emergency department, and we need to know everything they're on, what their treatments have been, what their allergies are, what their history is. Nobody has time to go back and read the entire electronic health record anymore, right? You can't, it's not like you can flip open a chart, and you need to be able to make decisions, even if you admit the patient and you want, you're there for a specific reason, you still need to know all the other stuff they have going on. And as a family member, and as a healthcare provider, very often I see these things get missed, right? Why are they suddenly like this? Well, oops, they're diabetic, and you're giving them, you know, all kind of dextrose, or they're not getting their medication, and they're having this response or this result. So there is actually the ability now to use natural language processing so that you can essentially ingest an entire electronic health record that latches on to it and can make sense of it. Now you can say, well, we kind of already can do that, right? If you type in a value of a blood pressure, we should be able to see what that value is. But that's not how we chart in healthcare. That's not how we document. We put notes in, we have progress notes, we have consult notes, we have radiology imaging where the radiologist writes a note about what they see in the report. So you can actually have software ingest all of those free text notes and make meaning of them, and then
Mhm.
instantaneously create sort of dashboards or however people prefer to read information that pulls it forward very quickly so you can see right away the important things you need to know. And it's just as good as knowing what questions you want to ask of the record and what you want pulled into those things. One of the companies I've worked with is a company out of Canada, and they created a tool. Their tool is called Darwin, but there's another one that I've helped them develop called Profit. But essentially, that's what it does. And they work looking at very large volumes of electronic health records. And the biggest project they have to date is working with the Canadian healthcare system to identify patients who are being treated who are not on the appropriate evidence-based clinical practice guideline recommendations for heart failure. So we know
Mhm.
heart failure is, pretty much, endemic at this point in time. And it's able to very quickly just look at all the records of all the patients who are being seen in primary care or in cardiology to say they should be on this drug, not that drug, or they should be having this procedure at this time. And it can put that list right back out by provider, and they can call the patient and make adjustments to their therapy. And by keeping something like heart failure under tight control, you can obviously prevent having to come to the emergency department, having to be, diuresed, all different pieces of the healthcare
Mhm.
continuum. You can avoid some of those pieces by making sure you're optimizing the care people are receiving. So that's one area where it's being used to really optimize and to help prevent missing things that can have an impact then on somebody's clinical outcomes. Even knowing follow-up. So the second layer to that is something that I did for a long time was work with transitions of care and trying to help people know what are they supposed to do next? When do they follow up? Where do they follow up? Who do they follow up with? Especially if they have multiple specialties. I'll use the example of stroke. A lot of folks who have stroke, it's not a one-time thing. They have a lot of comorbidities. They have a lot of risk factors. They might have multiple TIAs. They might be managing with blood thinners so that they don't have another stroke. They might have atrial fibrillation. And understanding, okay, wait, I'm supposed to be on dual antiplatelet therapy, but I'm supposed to stop it in 3 weeks, right? These notes get embedded in the record under that cardiology consult note, right? Or if it says 3 weeks, but how long were they in the hospital? Maybe they were in the hospital for 2 weeks, but then we leave them on it for 3, and then they come back with a hemorrhagic stroke because they were on dual antiplatelet therapy for too long. So being able to find words and make meaning out of notes to say these are all the discharge implications so that whoever's coordinating those instructions, that transfer, maybe it's a navigator, can really understand how to guide the patient, the family, and how to make sure that they're coming for their appropriate follow-up. So that's one way. So I'm going to shift gears to a totally different way, and that's in imaging. One of the biggest issues we see, particularly in elderly, are chronic subdural hematoma, issues where people have a change in their mentation. Maybe they fall all the time. Maybe we don't know if this is a hemorrhage that is going to keep coming back, if this is because they hit their head. What's going on? The patient's just confused. Maybe they didn't fall at all. And there are ways now with imaging that there is software that can be used. It's an overlay to a CT scan, and it can show you the volume and the consistency, if you will, of the hemorrhage. In a subdural hematoma, it's now being used in aneurysm. It's used for ischemic stroke. It's used to look for large vessel occlusions so that we know if that patient needs a thrombectomy or if they need to transfer to a hospital who's capable for that. And that software is used basically, well, to date, it's been used based off of a CT scan, and it was a
Mm.
CT angiogram, and then also sometimes CT perfusion. There are now AI algorithms that can use just a non-con CT with no contrast to be
Mhm.
able to determine, for example, if someone has salvageable brain when they're having a large vessel occlusion. So when they have a large artery blocked during their stroke, would they benefit if we removed that occlusion? Or is that brain already completely infarcted and there's no tissue to save, and then we could potentially cause a hemorrhage if we open up the vessel. So that software, there are now multiple iterations, generations of it, but that's one way we can very quickly make decisions in very critical situations because all of those are time sensitive. And
Yes.
we know very much that the door to treatment is going to make the difference whether somebody is independent or if they're going to be dependent or even, worse, if they won't survive the injury. And we need to make the decisions quickly. And AI gives us information to know I need to call a helicopter, or I don't need to do anything, or I need to take them straight to the interventional suite. Or I need to reverse the medication that they were on because they're hemorrhaging, and we need to make sure that we start them immediately on therapy to reverse that. So there are lots of ways it's being used now. And the last piece about that particular type of technology is that it immediately notifies the providers who are going to make the treatment decisions or treat the patient. So it used to be, if you imagine the cascade of, well, first we do this, then we do that, then we call this person, then we call that person, then they have to go read something, then they have to call someone, then they come in, right? So
Yes.
the amount of time gets longer and longer and longer. Whereas if the 2 minutes after that CT scan is done, if the person who's on call to actually do the procedure is receiving it on their cell phone and they can go, yep, activate the team, I'm coming in, and be at the patient's side and begin the treatment immediately, we're giving them the best chance for a good outcome. So that's one more way. I think I have time for maybe one more.
Yeah, keep
Um,
my mind is and folks, if you I mean I have so many questions that what it just does is silence me because I was like, this is so helpful. If people do have, well, there is a question. I'm seeing our friend Sue just put, how are you seeing AI being used to include patient reported outcomes and the content found in open notes?
So me specifically, I'm none of the companies I work for use that, but I do know from working in healthcare systems, patient-reported outcomes are very often used to build a very large database. There are a lot of registries that are using those outcomes, but the reason being is that then they work backwards. We've seen where people are using the patient-reported outcomes tied to the procedure and sometimes even evaluating um, the quality and the route taken during surgical procedures to then say, wait a minute, patients report doing better if we did X versus Y. So
Interesting.
there are AI modalities being used to then trace to how did we treat the patient? Should we do something differently? The other piece about it, honestly, is that you're able to get such a large volume from a very diverse group of patients when you use this, that you can say this type of patient does better with X, whereas that type of patient does better with Y. So that's where I think we're seeing the utility of the patient-reported outcomes and then also being able to tie it to the care, treatment, and services that they receive.
Yes, and I see. Well, there's a point in there saying Gita. Oh, it just went up. Sangita just up, uh, sharing as an FYI where we might be headed with AI. One of my friends who is an ER physician, she and her group have stopped using AI for documenting notes, and they strongly believe that it might replace them in the near future.
Mhm.
So that's that pushback or backlash.
I've seen that concern, and really when you think about it, you should always make your decision about what's going on with the patient before you look at any AI. Because what that does is it takes your clinical judgment and then you can apply the AI. I have seen many cases where the human eye has missed something.
Yeah.
I've also seen cases where the AI didn't pick it up, but the human did. So it is an augmentation, it's a tool, it's a resource, it's not a replacement. Also, AI can't make the decision of what to do next, right? Now, there is AI being used to capture voice to text. Very simple. We do it all the time. Every time you text, right? But what it's doing is it's allowing the conversation with the patient not to be interrupted with documentation. So it is taking all of it's basically recording, just like we're doing with this meeting.
Yeah.
And then it's transferring it into the electronic health record in the appropriate places So things like history and comorbidities and patient reported symptoms, and it's just filing it in there for us so that you can make eye contact and talk to the patient and not worry about being into the computer. So
Yes,
that's another way I'm seeing
and
it be
Sue
used.
just referenced that. She says at the end, a physician visit, and the physician used AI to document our conversation so that the doctor and I could fully engage. And then this is, believe, an untapped source of information to reduce diagnostic errors, improve quality overall, and patient engagement. Uh,
Yes, and
it,
that's the
it is
idea of the natural language processing where it goes in and it's very nuanced, where it can actually, it's used in rare disease, it's used in dermatology, it's used in oncology, because it's able to take enormous amounts of information and for many, many, many people, and it's able to find this, for example, a cluster of symptoms over years to diagnose somebody sooner and
yes,
begin treatment sooner, especially when you think of our autoimmune diseases that have vague symptoms or different presentations where it can point somebody right away to say, this is a zebra, not a horse, right? When you hear the hoofbeats.
yes.
So it's very helpful in bringing together large volumes of information, but nuancing it to what you're looking for.
And that's what I'm seeing. It must be who I'm following on AI, on LinkedIn, that AI is a predictive model to be able to diagnose Parkinson's many years earlier, to be able to diagnose dementia many years. I think because it's Brain Health Month, there's a lot brain
Yes.
dementia.
Absolutely. And you look, it simply looks for patterns. It looks for patterns over time. It looks for results and outcomes, and then looks at what the patterns were leading up to that. And then it can become predictive because it says, oh, when we saw this, along with that, and then this also was going on, that this percentage of the time, this is what we found down the road. So
Mhm.
it's how we're able to get treatment started earlier or to know to look for certain things. Then we know to look for certain biomarkers, right? Or maybe to do certain tests or certain imaging to say, let's be suspicious for this. So it's very helpful in that way. Um,
Exactly. And we're seeing, exactly, for these longer term diagnosis issues with autoimmune diseases. Deborah just point, like, for example, with lupus. What I like about it,
Crohn's colitis is another one, and there's a company out of Israel that's working on being able to diagnose many years sooner for individuals to get that under control. So
Crohn's
um,
and colitis. Okay.
it's really valuable in those types of diseases that are often missed or misdiagnosed. AI is helping us make great strides there. The last thing I'll talk about, for time's sake,
Yes.
is there is a company I work with now. They're called Ceribell, and what they do is they have built algorithms where they're using what's called point of care EEG. So instead of, okay, you're in the emergency department, we're not sure what's going on, you're not kind of responding the way we expect, it's able to just take a headband, put it on the patient very quickly, instead of all the, calling in a tech, hours of gluing leads on. And it can tell you based on an algorithm the percentage of seizure activity over a period of time. And it's the FDA has approved it for diagnosis of non-convulsive status epilepticus. So whereas before you would typically say, well, we're going to intubate, we're going to give some meds, we're going to send them to the neuro ICU, and then we're going to put somebody on monitoring. Think about all of the implications of that. We've just created a critical care patient. Whereas if you can use that and identify that they're not having seizure activity, we can avoid all of that. And on the flip side, if we medicate and intubate and then monitor later, we might have broken the seizure and then they won't seize again and we'll think that they weren't seizing. But there's a lot of guidelines coming out from Society of Critical Care Medicine, American Heart Association, for different things like return of spontaneous circulation after cardiac arrest, that we need to be doing prompt EEG. And in most hospitals in the United States, prompt EEG doesn't exist. I had responsibility for a level one trauma academic public safety net hospital in Atlanta for 8.5 years, and I had a fully staffed neurodiagnostic lab. But you didn't ever do EEG in the emergency department, right? It wasn't a triage tool. So we think about it like the same way you have CT, the same way you have EKG, the same way you have labs looking for sepsis. we now have something that can be like a stethoscope of the brain to look for seizure. And what most people don't realize is that it crosses all of these different concerns that we have: subarachnoid hemorrhage, ICH, stroke, which all of those very much, cause, it's the leading cause of disability in the United States in adults. So we really understand that there's a lot we can do to treat sooner, because if a brain is in non-convulsive status, we don't know, but it's causing damage. And a lot of patients will end up at best with cognitive disabilities, but it can cause a person to absolutely have brain death. So being able to find it very quickly and treat it very quickly is another way that this algorithm tied to the device, and actually the CMS has granted them a new technology add-on payment because of, and it's really the first device that's ever been given that, because of the value in being able to identify this so quickly and easily that you can treat it so that the patient has a better clinical outcome. And it's the algorithm, not the device, that has the new technology add-on payment. It's using that AI that allows for that. So
Well, this was a great Friday appetizer, cocktail teaser. I mean, of just so much. It is the one part of AI that hasn't scared me as much in the big umbrella of it is the
good.
positive uses for healthcare. And then thank you for giving a deep dive into the EHR analysis and the imaging and the notification and the predictive. And then for me as a public health person, I also love and a patient and caregiver, not just the applications for the individual and our family members, but the applications to do understanding about a group of people, whether it's a group of patients or a community. Thank you, Dr. Karen Seagraves. You will be back already. There are so many questions. You can see that folks we have a number of folks here that advocate, especially in the rare diseases. And so being able to find those zebras out of the herd of horses,
Yeah.
that analogy.
Thank you so much. If you're curious about reading more about it, it's a colleague of mine who started that company in Canada. They're called Pentavere, and those are the ones using that natural language processing. It's Pentavere, and they have really been able to help in a number of spaces. So just if you're interested in reading more about them, that's where you can look for that, since you were very interested in the zebras.
Yes, and maybe that's a good sign off, but let's stay connected. What is the best way for folks to stay on top of this? Because there's a flood of information. We need AI to analyze the information for us, just what's
Hmm.
coming out.
Hmm.
Should they follow you? Is there a favorite website? Like for people that are interested, like I just follow a bunch of people on LinkedIn and then
Yeah.
up to.
I would say, I mean, I follow so many different sites, it's tough to say the best one, but one of the things that I like is I really trust things when they have, FDA, 510K, um, you know, or they're coming out of really trusted academic institutions who are doing an enormous amount of research. So there are really some very strong neuroscience programs around the country where they will share the outcomes of the work that they do. But I caution you in looking at just like one single device company, or because a lot of them will try
With
to
the
solve your
product.
problem before they know the problem that you have, right? They might have a solution, but
Yes.
what's the problem? So I would say sticking with things like the FDA um, or NIH, or the the NINDS.
Hmm.
Those are areas where you're going to see if there are approved treatments, but also the clinical practice guidelines. American Heart Association actually added the software for detection of large vessel occlusion to their guidelines for ischemic stroke. So if it's in the evidence-based practice guidelines, all the guideline updates for the diseases or the populations that you're interested in, that's the way to really stay on top of things.
Okay, well, we need to let you go. You have a plane to catch.
Yes.
He's on our way to Ireland. Really, Dr. Karen Seagraves, thank you so much. This was worth the wait.
Thank
And
you for
now that you've
having
been,
me.
we're so going to have you back soon to talk more with us. Thank you. Thank you.
Terrific. Thank you.
Okay, we'll let you go.
Bye.
Bye.